Okay, good afternoon, and a quick overview of the measles rubella surveillance in India. What is the current system and what is the way forward for surveillance. Again, going back to our morning slide on the strategic plan for measles elimination and rubella and congenital rubella syndrome control in the region. As I mentioned in the morning, there are 4 strategies: immunization, surveillance, laboratory network support and linkages, and we've talked a lot about immunization since morning. I'll just focus briefly on the surveillance aspect, especially with a focus on India, and then stop. So this is the surveillance presentation, and a sensitive surveillance system, as we've been discussing since morning, for measles and rubella is critical to achieve the measles elimination and rubella CRS control goal. Now, how the surveillance is set up in India? The surveillance system is supported by WHO's National Polio Surveillance Project, and it is using the AFP surveillance as the system that they've been using for AFP surveillance as a platform. The surveillance rubella is backed by a laboratory network, which I'll show you. The surveillance for measles and rubella has been scaled up in a phased manner over a period of 10 years, between 2005 and 2015-16, that was the period when the whole system was scaled up to start surveillance for measles and rubella. It is an outbreak-based surveillance system, but is in the process of shifting to a case-based system, and I'll describe what these two things mean in my slides. So first on the scale up, and this is how it's scaled up. As I said, it started in 2005 with Tamil Nadu being the first state in India to start surveillance for measles and rubella using the AFP surveillance as a platform. And then over the next 8 or 9 years, there were 1 to 3 states that got added to this system. It was only in 2014, when 18 states, and then in 2015 the remaining 2 states, which means that between 2014 and 15, 20 states were added to this system. And why in 2014? 2 reasons. One, because by that time India had introduced 2 doses of measles containing vaccine in all the states, so as you saw from Dr. Haldar's slide in the morning, 2010 to 2013 was the period when the second dose of a measles containing vaccine was introduced and added to the routine immunization program in the country in a phased manner. So by 2014 all states had done that. Also 2014 was the year when the region, WHO's Southeast Asia region, was certified polio free, so that was the time when, the focus started shifting on to measles and rubella surveillance and immunization activities, and therefore this 20 states got added, the remaining 20. So by 2015, all these states have now introduced the laboratory-based measles rubella surveillance. What they are using as the backbone of the surveillance is the reporting network that was reporting sites in the network. They are of 2 types. They are called reporting units or informing units. Now, reporting units are those that send a report of AFP and suspected measles cases every week, irrespective of whether they see a case or they don't. The informing units, which are about 30,000 or so, they inform the system as and when they see an AFP or now a suspected measles case as well. And you can see, in the pie that shows that there are a lot of non-allopathic system practitioners also. They are the Indian system of medicine practitioners in the net. There are even quacks in the villages and who are reporting AFP as well as measles and rubella, suspected measles cases to the system. and the government and private sector is represented in this. As you can see, there are more private practitioners and centers that are a part of this reporting network than the government system. So there's a lot of reliance on the private sector as well for reporting these suspected measles cases. The case definition that is currently in use in India is this, that any person with fever and maculopapular rash with one of the three C's, cough or coryza or conjunctivitis, or any person in whom a clinician suspects measles infection. So that is the definition that is used to report suspected measles cases to the system that are worked further on. So then once these cases get reported, the suspected cases, there is a trigger. As I said, this is an outbreak-based surveillance system. So this program is not chasing every suspected measles case. It is only investigating potential outbreaks of measles as of now. And what is the trigger to flag a potential outbreak? This is what it is. 5 or more suspected cases of measles in a block or in a planning unit area in 4 weeks duration. So if that's happening, then there is an investigation that gets launched, or if there is one or more suspected measles death in a block or in a planning unit during a 4 weeks duration, or if there are 5 or more suspected cases in an area that is bordering multiple contiguous blocks or planning units, again over a period of 4 weeks. So that's the trigger to flag a potential outbreak. Now, how the system works is that there is a desk review of the measles data that is done every Tuesday. So in a district, a desk review is supposed to be done, looking at the data of the last 4 weeks of suspected measles cases, and if there are 5 or more cases in the block, or if there is a death that is probably related to measles in a block, then a suspected outbreak gets flagged, and there is a preliminary case search that is done for additional cases. If there is a clustering of 5 or more cases in the area, a very detailed outbreak investigation is conducted. And this outbreak investigation involves a house-to-house search. It involves serum sample collection from 5 suspected cases, and it also involves collecting throat and urine samples, to isolate the virus and do a genotyping. And of course, there is a case management and a line listing of all these cases. So that's how the system is operating in most of the states of India. The serum specimen testing protocol is that for these suspected measles cases from whom samples are collected, there is a measles IgM testing that is done on the serum. If it is positive, it is confirmed as a measles case. If that's negative, then that serum is subjected to a rubella IgM testing, and then if it comes positive, it's confirmed as rubella. If it's negative, it's discarded as non-measles, non-rubella. The samples of throat swabs and urine are tested for virus isolation and genetic characterization from each outbreak that is investigated in the country. Now, to do this testing, there is a Measles Rubella laboratory network, and there are 12 national laboratories and 2 national reference laboratories that are established all over the country, where the samples are sent from all parts of India. And you can see, the number of samples that this network has been testing. This is a WHO supported network, which means that WHO ensures supplies. WHO ensures support to human resource training. WHO also supports data management and also ensures quality assurance. So there is a method to ensure that the WHO supported laboratories are proficient and are performing the test with due rigor to the quality that is required. The number of samples, as you can see, has been increasing over the past few years, and especially in 14-15, because almost all of the all states of India were now sending their samples to the network, and nearly 9,000 plus samples have been tested over the last 1 year, 2 years for serum. And there are also throat swab and urine samples that are also being tested now, about 400 to 700 of them over the past few years. The breakup of these the measles and rubella cases that have been reported in India by their classification category. As I said, some of them get lab confirmed, but then if there is an outbreak and we are collecting a few samples, and if that is labeled as a measles outbreak based on the fact that the samples collected from the those outbreaks have tested positive. All the other cases in that outbreak are called what we label them as epi-linked or epidemiologically linked outbreak. And then there are, there are non-measles and non-rubella cases. So if you look at these pies, this green portion is showing the number of suspected measles cases that were not investigated. They were not investigated because they did not fit into that definition of a potential outbreak, and therefore they remained suspected measles cases without any investigation. The red portions that you see are the laboratory confirmed cases, for which the samples were sent to the labs and they came back as positive for IgM. There are also the pink portion, which is the epi-linked cases. So there is those cases were a part of that outbreak that was confirmed as measles or rubella. And they were 9% or 5% in 2017, where they were neither measles nor rubella because they tested negative for both IgM, rubella, and measles. So the point that we need to remember is that there is a large proportion of these suspected measles cases that are not investigated so far. Because they're not a part of an outbreak, and this will have to change, and when I talk about the way forward, and as we get closer and closer to elimination, as we do these campaigns that Dr. Haldar described in the morning, as we improve our coverage through routine immunization, we're going to start getting lesser and lesser number of cases of measles and rubella, and that will be the time when, we'll have to shift to what we call as a case-based surveillance, which will mean that every suspected case will have to undergo an investigation, including a sample testing in a WHO accredited laboratory. So we'll come to that later, but looking at the performance of the measles rubella and looking at the indicators against some standard global targets, if we look during 2016, what percentage of the suspected cases had a serum sample collected? While the globally recommended target is 80% or more, only 22% had a serum sample collected, and it's all right. I mean, I think India was not doing anything wrong, so don't take it that way, because the load of measles and rubella right now is very high in India, and the coverages are not high enough to have reduced the transmission. This is probably the best way of doing surveillance at the moment. It will not be the best way as we go forward, but so far it's all right. The non-measles, non-rubella discard rate per 100,000 population is another indicator. It's an important indicator to measure the surveillance performance, and the globally recommended standard is 2 or more non-measles, non-rubella discarded cases per 100,000 population. India had only 0.17. The percentage of districts that are reporting non-measles, non-rubella discard rate of 2 per 100,000 population was only 10% against a recommended target of 80%. Now the percentage of suspected outbreaks investigated was 55% against a target of 80% or more, and the percentage outbreaks with genotype data available was only 21%, And this again, the genotypic information is going to become important as we move towards the elimination. I mean, I should have mentioned in the morning that we have a member of the Southeast Asia Regional Verification Commission sitting in the room as well, Professor Dubey, who is a member of the commission, and he's a part of the commission that looks at all these things, when we will present the case to the Regional Verification Commission from India, saying that we have actually achieved elimination or we are close to elimination. The commission is the one that looks at all the evidence and looks at all these indicators and then decides whether the country has actually achieved elimination or not. So while India is doing all this surveillance, there's a lot of data that is getting generated, and this is just one example that I wanted to give to you, on looking at the measles. These are confirmed measles cases by age and vaccination status, and I think Dr. Jacob John already showed this in the morning. A large proportion of the cases are in the 1 to less than 9 years, some in 10 to 14 years age group. But then when you look at their immunization status, nearly 50% of these confirmed measles cases have not received even a single dose of a measles containing vaccine, and some have received a single dose, and some have received more than one doses and yet have got measles, which is not absolutely all surprising. It does happen. Now, so that's the outbreak-based surveillance and the data that we're generating from it. India is in the process of transitioning to a case-based measles rubella surveillance system. And what does that mean? As I said, when we say case-based, we're going to be investigating every suspected measles rubella case that gets reported, and all these sporadic cases are also going to get investigated. So we're not going to wait for an outbreak to be identified and then only investigating outbreaks. Serum samples and throat swab and urine samples will be collected from every suspected measles rubella cases that is reported. Every Tuesday, the district review will continue to be done based on the weekly reporting. And if there are 5 or more cases that are clustered or death in a 4-week period in a contiguous area, that will also be labeled as an outbreak, and then the same detailed outbreak investigation as per the existing protocols will be conducted, which means a house-to-house case search, a line listing of all the suspected cases, including any deaths, serology samples, virology samples, and case management. So that's the difference between an outbreak-based and a case-based surveillance to which India is moving. And India is moving in a phased manner again. It cannot move in one go. So already there is one state, that is Karnataka, that has already started doing case-based surveillance. There is a plan to move on to other states as well. Trainings have already been initiated in some other states. States with more than 90% of first dose measles containing vaccine and an improving second dose measles containing vaccine coverage are being taken up in 2017. All the rest will follow the completion of the measles rubella campaigns, because the expectation is that once the coverage through either routine immunization and or supplementary immunization is increased, the number of cases will decline sharply, and once that happens, we should be latching on to the opportunity to do a case-based surveillance and get more accurate information on where the virus is transmitting and what are the pathways of transmission. So just to give you an example from Karnataka, which has already moved on to the case-based surveillance. So if you look at the non-measles, non-rubella discard rate, which for overall India is 0.17, and for Karnataka, if we look at a period of September 2015 to April 2016 was only 0.04 against a recommended target of 2. This has improved to 0.5 now, so it's still not ideal, it's still not optimal. When you look at the September 2016 to April 2017 data, there are 1.4 times more cases that have been investigated and 7.5 times more samples that have been tested. So even if you look at the maps, the map on the left shows the investigation and the confirmed cases that were in localized districts, whereas the map on the right shows that now investigations are happening and we are getting confirmation of measles cases from almost all districts of Karnataka. Of course, now the campaign has been conducted, and we are hoping that this will serve as a good baseline to measure the progress following the campaigns and see the impact of the campaign that has happened in Karnataka. So just to summarize that there is laboratory supported outbreak based surveillance that is ongoing in all the states and union territories in India. The surveillance performance at the current moment does not meet the globally recommended standards that are required for verification of elimination of measles. There is a plan to shift to a case based surveillance to enhance the sensitivity of surveillance. The initial results from this surveillance are encouraging. Now, in terms of the way forward, so what is the plan, what India should be doing as it moves towards achieving surveillance sensitivity that meets the global targets and recommended standards? It should initiate case-based surveillance system in all the states. As there is a plan, so it's important that the plan is implemented and all states move on to the case-based surveillance system. There is a need to review and expand the reporting network to beyond the AFP reporting sites. We're talking about 40,000 reporting sites. These are mostly hospitals and pediatricians, big nursing homes, medical colleges, district hospitals, and PHCs. But we know that the health-seeking behavior when it comes to measles is very different from what it was for AFP, and therefore a lot of these measles cases may not reach any of these sites. So it's important that a review is done and an expansion of the reporting the network is undertaken, trying to involve more of the community workers, because the Ashas and the Anganwadi workers and the ANMs are the ones that are going to get the information of these suspected measles cases more than the big hospitals. What we see in the big hospitals are only those that have ended up with complications, so most of them are not going to be reporting to these hospitals. So the third action that is probably required and is under consideration of the program in India is a broadening of the case definition of suspected measles by shifting to a definition of just a fever and a maculopapular rash, and that is dropping the 3 C's, the cough, coryza, or the conjunctivitis. This is the standard definition that is recommended by WHO as per the WHO position paper that was released earlier this year, that all countries should move to a fever and maculopapular rash, trying basically to increase the sensitivity of the surveillance. The fourth action that is required is ensuring serology and virology in at least 80% of the suspected cases. This is a globally recommended target and should be met, should not be difficult once India moves to a case-based surveillance. But then what this is going to mean is an increase in the workload for the laboratories, and therefore it will be important for India to enhance the laboratory capacity to meet the requirements of these increased sample load for serology and virology. We've done a assessment only 2 weeks back on what is the capacity of the labs in India, and there is no concern at the moment. Even if India moves to a full case-based surveillance, the laboratory capacity in India is sufficient and is going to be able to manage the increased workload. Even if the number of cases, if India was to meet the non-measles, non-rubella discard rate of 2. And then, of course, the last but not the least is why are we doing this surveillance? We are doing this basically to help the program. So there is a need to frequently review the surveillance data, both at the national and sub-national levels. And when I say sub-national, it means district and sub-district level as well, to ensure that there is adequate and appropriate public health response to the outbreaks that are detected. There is guidance provided by the surveillance data to the policies and strategies to achieve measles elimination and rubella CRS control in India. Dr. Jacob John mentioned in his presentation that, we might get tripped by, a number of factors that we are not even looking at right now. It's going to be important that we look at the surveillance data, we keep a watch on those things, and if there is a need to change our policies of vaccination, campaign, age bands, whatever, we do that based on surveillance data, and then of course measure progress towards the achievement of the goal, and then ultimately present to Professor Dubey, that we've done it. Otherwise Professor Dubey is not going to listen to us. Unless we demonstrate that we have good surveillance, just going and telling him we have no measles is not going to, give India the certificate that measles is gone, unless we also show that surveillance is good and measles is gone. So that's it. Thank you very much for your attention on that.